Now, the next talk will be by Dr. N. Sandhya. She'll be talking to about tips to make nuclear management easier.
Now we have discussed about wound construction in topical phaco. We'll move on to nucleus management in topical phaco. This patient had nuclear sclerosis grade 2 to 3. Pupil was dilating well. The microscope illumination was reduced to cause minimum discomfort to the patient. So after a good corticocleavage hydrodissection, OVD was injected and nucleus was tapped in the center to release the trapped fluid. Now the nucleus rotation should be very gentle so as to reduce the sonular tug on the ciliary body, which can cause pain. Now the cornea was moistened with OVD. This can avoid frequent irrigation with BSS solution. When you're introducing the phaco tip, you should not overinflate the anterior chamber with OVD. It should always be underfilled, and you should reduce the infusion pressure because the sudden deepening of anterior chamber can cause stretching of the ciliary body and pain and discomfort to the patient. You can select your choice of nucleus strategy, but here I am doing a stop and chop. Now after about 80% of the depth of the nucleus is trenched, now this was split into two halves. During all these maneuver, care should be taken not to engage or touch the iris, which can cause pain. And after splitting this into two pieces, each of this piece was then subchopped. That is, the phaco probe was embedded into the nucleus. The probe was lifted up and the second instrument was pushed down, so the nucleus is split and then it is separated laterally. Now during nucleus management, globe fixation is not a big problem because there are two instruments within the eye, and so the patient won't be moving the eye too much. And also by this time the patient would have got used to the microscope illumination. Now each of these pieces was brought into the anterior chamber, and then before taking out the phaco probe, OVD was injected so that there is no sudden shallowing of anterior chamber, which can also cause some discomfort to the patient. So the endothelium was protected with dispersive OVD, and then the nucleus pieces were emulsified very carefully. Now there are only two situations when you fill the anterior chamber completely with OVD in topical phaco. That is just before capsulorhexis to keep the anterior capsule flat, and also before insertion of IOL. So sometimes these patients can move their eyes, so we should be careful about that. And then these nucleus pieces and the last piece of epinucleus was emulsified. And again, before taking out the phaco probe, OVD is injected, and then the cortex was removed. And in this patient, at the end of nucleus emulsification and cortex removal, there were some epithelial plaques that was attached to the capsule. So the stabilization of globe is very important in this stage, and you should keep the irrigation very close to the posterior capsule so that it doesn't come up and it is caught by the aspiration port. And also you should avoid leakage of side port. Actually there is some leakage, but it should be avoided. Then when the anterior chamber was filled with OVD, patient complained of pain. So I have to supplement topical anesthesia. So here I am injecting subconjunctival silocaine 2%. So the conjunctival stretching causes severe pain. So you have to anesthetize the area with a paracaine soaked cotton tip applicator, and a small amount of silocaine is injected subconjunctivally. Then wait for some time and then inject very slowly so that there is no sudden stretching of the conjunctiva. And then you can just push this silo. You can take it all around the limbus, so that there is the entire area is anesthetized. Now this I have seen in one of the videos of Dr. Saurav Patwardhan, and this works very well. And after that, I could complete the procedure without any pain. Now in this patient had a very soft cataract, and the capsulorhexis was done under femto platform. Here there was a small area of attachment of the rhexis, and so that was removed carefully and the flap was taken. And then Since the cataract was very small, it was flipped out of the capsule using very low power, but again it got eaten up, and so I had to lift it up again with the dialer, and then the entire nucleus was emulsified in the epinuclear mode. Now in this patient with soft cataract, the nucleus was prolapsed into the anterior chamber, and I did a supracapsular emulsification. During all these procedures, you should protect the endothelium with a dispersive OVD. And in very soft cataract, this strategy can be adopted in topical phaco because more manipulations can be avoided. So this was a patient with a medicated stent. So the cardiologist didn't want to stop antiplatelet. So even though the cataract was hard and mature, I had to operate topically. So after a careful hydrodissection, since so as not to increase the back pressure, the loose cortex was aspirated bimanually. And then I made a deep central trench and then tried to chop the nucleus. But since I could not crack the posterior plate, so there was this central nuclear button. So once this button comes, then you will have to eat it up. Otherwise, it will block bringing the other pieces into the anterior chamber. So once the disc-like central core was eaten up, then the rest of the nucleus was chopped into smaller pieces. But still, I could not break the central attachment at the bottom because I didn't crack the posterior plate initially. So each of these pieces were slightly pulled to the anterior chamber. Then I just trimmed it above the attachment point, that is the common pedicle there. Then by the time this nucleus flipped off, heminucleus, and then it's a safe way is to just reposit it back after filling the anterior chamber with OVD. But here I just lifted up it, and then I am here breaking the central attachment. So whenever there is a common point of attachment, that is a pedicle sort, you have to initially sever that attachment. So then further nucleus management becomes very easy. Now in this patient, I am trying a horizontal chop. So once you can see, this video is not. So once you can see a central red reflex there, you can split the nucleus, and then you have to rotate it into two halves. And then what you have to do is you have to impale the phaco probe into the half. So once you see the red reflex, you can then split the nucleus into two halves. So that means that you have reached enough depth, and then each of this half was then chopped. That is, you have to hold the piece with a phaco probe and then take the dialer under the rhexis margin, hook the equator, and then bring it through the lens to the probe so that the horizontal chopping will be done. So to summarize, we should avoid very hard and intumescent mature cataracts for taking these very hard and intumescent mature cataracts for topical phaco. A good hydrodissection and slow and careful rotation of the nucleus is important. Underfill the chamber with OVD and lower the infusion pressure while introducing the phaco probe. Care should be taken not to engage or touch the iris. Use OVD to moisten the cornea, and also you should avoid sudden collapse of chamber while withdrawing the phaco probe. And glove fixation is less of a problem during nuclear management compared to wound construction and capsulorhexis. Thank you.
Thank you, Dr. Sandhya, for that very illustrative talk on nucleus management. Take-home point will be, although the section will be painless, sudden inflation and deflation can definitely cause discomfort to the patient. And if possible, once you enter with the phaco probe, it's preferable you finish everything and come out. Multiple going in and coming out, especially without replacing with viscoelastic, may be a slightly difficult thing for the patient to tolerate. And whenever necessary, we should augment with either intracameral or, if needed, subconjunctival.